I think so. Beverly Ann Wood, Wood.
Dr. Wood, where are you employed?
I'm employed by the South Carolina Department of Corrections.
And how long have you been there?
13 years.
And what is it that you do?
I'm the chief of psychiatry there, but I also have a caseload and I manage all the psychiatric services for the Department of Corrections.
And can you tell the jury a little bit about your educational experience and background?
Yes, I went to undergraduate school at Virginia Tech. I went to medical school at Virginia Commonwealth University, the Medical College of Virginia in Richmond, Virginia. I did my psychiatry residency at Penn State University's medical school, which is in Hershey, Pennsylvania. And I also did a fellowship in child psychiatry, but I didn't actually work in child psychiatry. I worked 2 years for the Pennsylvania Department of Mental Health. Then I came to South Carolina in 1991, and I worked for the South Carolina Department of Mental Health until 2006, when I came to the Department of Corrections to be chief psychiatrist. And I've been there since that time.
During this time, it's best moved that Dr. Wood be declared an expert in psychiatry.
Mr. Bordar.
Limited to psychiatry, Your Honor.
Very well. Dr. Wood is offered for your consideration opinions in the field of psychiatry.
Yes. Thank you. Dr. Wood, can you tell the jury a little bit about how you became involved with Tim Jones?
Yes, I happened to be covering the unit that he first resided in. That was one of my areas of responsibility when he came to the Department of Corrections. So he came as a pre-trial detainee. Sometimes we get people that haven't been to trial yet, mostly. Most of our inmates have already been to trial, but we get a few that haven't. And I evaluated him and treated him. And then when he was moved to another campus, that's one of the campuses I covered, so I continued treating him. So I treated him during his entire stay with the Department of Corrections.
And do you know the dates for that entire stay at the department?
He came in September of 2014, I think the 12th. I'm not sure the day. September 2014, and the last time I saw him was in December of 2018, because I don't know the exact date that he came back to Lexington County, but that was the last time I saw him. It was in December.
And if Dr. Parson had testified that the dates were September 12th, 2014 to May 9th, 2017, that he was at Kirkland, and May 9th, 17 to January 23rd, that he was at Lee. So those dates sound right?
Probably.
Okay. So when you first saw Tim, can you tell us how that went? What was that about? What was he like?
I first saw him basically to obtain history and figure out what's going on. People don't generally come to us with any information, so we just interview them and try to get as much information as we can, which is what I did. And you want me to talk about the actual interview? Is that what you want me to talk about?
Yes, ma'am.
Yes. Okay. He gave me a family history of schizophrenia. Said his mother had suffered from schizophrenia. He said that he had started hearing voices, I think around age 12, I think is what he said. He had a head injury in an automobile accident, and that was in his teens. I don't remember the exact age. I think he told me he started using drugs around age 15, started with alcohol, progressed, used a variety of drugs, marijuana, synthetic marijuanas, cough syrup, had used cocaine, occasional ecstasy, I think he said.
So did you obtain a history of his drug use? Did he tell you about that?
Well, yes, he told me what he had used, and I mean, I didn't get information about how many times a day and that type of thing in that initial, but he did give me an extensive use of drugs. I think he said cocaine was his drug of choice, but I don't think that was the one he'd used the most, though.
Did he tell you about the use of synthetic?
He told me he had used synthetic, yes. He did tell me that.
And at that time, did you start a working diagnosis? What did you do?
Well, I mean, based on his mental status exam, when about the voices he said he heard, he said he saw more like strange things. Sometimes when he looked at the walls, he would see like shapes or movement, sometimes faces. He'd been depressed. He said, I guess he was kind of a loner, I gathered, for most of his life. He liked to do things fast, and I think he said he ran wide open sometimes, had been depressed sometimes. So I thought there was a psychotic component with the voices. He also expressed a little paranoia. And I thought there was an affective component because there were some bits of maybe hypomanic or manic behavior, although he did not give me a history of a full-blown manic episode, and some depression. So my working diagnosis that I gave him at that time was schizoaffective disorder, although there was also a history of substance abuse. Sorry, my mouth is dry. And I had to rule out personality disorder because he said he'd been in troublesome in his youth. So that was a rule out, too, that I put in there.
Did you originally start out as psychosis not otherwise specified?
Probably, yes.
And did you start him on any medication?
Yes, Geodon, which is an antipsychotic that's also a mood stabilizer. So.
Now, with Geodon, can you tell us like how that's taken, how it's absorbed in the body? Are there any special requirements?
Yeah, you have to have food in your stomach, at least about 360 calories in order for it to be effective, which is a little bit of a challenge within the Department of Corrections to time it with food. I mean, we're supposed to be giving snacks, but that doesn't always work out. But I like to use it because it is a good mood stabilizer and an antipsychotic, and the side effect profile is pretty good. I mean, it's generally people maybe get a little tremor, but the side effects are not usually as severe as with the older antipsychotics. And we have a list of preferred antipsychotics that we're supposed to use, you know, it's called a formulary within the Department of Corrections, so we try to stick to that whenever possible. So Geodon is one that I like to start with just because people usually tolerate it pretty well, and it's usually fairly effective.
Now, do you recall, like, how did he respond to the Geodon?
Well, I had to keep increasing the dose with him. I mean, he did respond. He said he felt better, but we didn't completely get rid of it. It took a while to completely get rid of the voices, and we mostly got rid of the permutations, or that's what he called them sometimes, the things he would see. But again, it was, so I used a much higher dose than I usually use. I tried to change, he did have a little tremor, so I gave him propranolol, which is a treatment for tremors of antipsychotics. We tried to switch to fluphenazine or Prolixin, which is an older, since we were getting so high with the Geodon dose. That was helping him, but then we were unable to obtain it from the manufacturer because they weren't making enough and it just wasn't available. The tablets, so we used the liquid for a little while because we could get that, and then that became unavailable. So we had to go back to just the Geodon, and then I think by the end we had added perfenazine or Trilofan, which is another antipsychotic, so we were trying to not be on so much Geodon. But throughout with the Geodon, we had trouble with the food, you know. I mean, for a while, I was able to give him Insure or Boost, and then we weren't able to do that. And they were supposed to start bringing snacks, and that worked better some locations than others.
Yeah, now, at the Department of Corrections, on the weekends, do prisoners get lunches?
They get 2 meals a day on weekends. That's why it's important to get the snacks, but the meds are mostly twice a day throughout, with the exception of a few special programs. The meds are twice a day, but on the weekends, they don't coincide with mealtime because they get a brunch and a dinner on weekends. So that's another challenge there.
I'm going to show you one of your notes from October 2nd, 2014. This would be a couple weeks after he had been on the Geodon.
Yeah, they said something doesn't feel right. That the voices had decreased is what wasn't completely adjusted to the medication.
And how did he feel now that the voices were decreased?
Well, I think he certainly liked that the voices were decreased, because I know later when we were on a really high dose and we were trying to decrease it, and he said the voices have returned, and I remember he told me I'd rather have brain fog than hear voices, because sometimes if you're on a lot of antipsychotic, the guys do tell me it's like thinking through a fog or something, and he did tell me that at one time, that he would rather have that than to hear the voices.
Now, did you consider the possibility that he was faking?
Well, in that locale, I consider that with everybody, because we do have a number of people that do fake for various reasons, to get in special programs or just for a variety of reasons. However, I never saw anything in his behavior that would confirm that or make me think that he was faking. I can't imagine somebody would. Generally, people that are faking don't ever make it to the doses of medication that he's on. They're going to tell me, yeah, that dose stopped, or they're going to ask me for something, or try to flatter me or intimidate me to get me to do something that they want done. There's just a lot of things that people that try to manipulate us do, and that happens a lot. That never happened with him. He never asked me to do anything or did any of those things, and he would tell me if the medicine was working or it wasn't working. He never suggested that I give him one of the medicines that they can sell on the black market or anything like that. So I did not, although I entertained it, I never felt that he was trying to manipulate me. And none of the staff ever told me they felt like he was trying to manipulate them either.
Is that something, like, I feel strange now that I don't have these voices? Is that something that somebody would say if they were trying to manipulate?
I've not had anybody say that, if that was trying to manipulate me.
At some point in time, you changed your diagnosis to schizoaffective disorder.
Yes, because I thought there was an affective component, because sometimes he'd have the pressured speech, and again, I never saw a full-blown manic attack. Some people with mania are happy, and some get agitated. So, I mean, he had described periods of agitation, which could be consistent with that. I mean, diagnoses in psychiatry are not as clear-cut. It's not as easy as it is in other forms of medicine. There's nothing I can measure, like a blood pressure or culture for a bacteria, because a lot of the criteria for the diagnoses overlap, and a lot of it's based upon the psychiatrist or the person treating or interviewing. So that's a big criticism, I guess, with the DSM-5s, and it takes years for them to come up with new books because there's so much controversy. So
now, on October the 9th of 2014, did you add Prozac to his?
I added it at one point in time. I don't know if that was the exact date, but I did add Prozac when he said he was depressed, yes.
Now, had he already told you that the voices were starting to go away by the time you added the Prozac?
I don't know. I don't know for sure. But it's not unusual if someone is hearing voices and depressed that I would use an depressant and an antipsychotic. Although Geodon is a mood stabilizer, it's not a great, by itself, antidepressant.
At some point in time, did you discontinue the Prozac?
Yes, he hadn't. We were switching to a new medical record system, and not all the medication orders were going through, so there was a problem for a little while. And I think he was without the Prozac, and he said he didn't feel any different without it than he did with it, and he didn't see a need to continue it, so I was okay with that.
Did he continue to be stable for about a year after you discontinued the Prozac?
There was a long period of time that when he would rate his mood, I think when the counselor went by regularly, and he would say he was 8 out of 10, he was okay. So, I mean, there was a period of time that he was doing fairly well, yes.
I'm going to skip ahead to the August of 28th of 2015. That would be the anniversary of the children's status. You recall that day?
I know that I wasn't present when it happened, but he had made a suicidal gesture or attempt. Some rules had been, I guess, enforced in the program he was in that are usually, had been enforced in the lockup units, which is that when medication is distributed, because it's done through the door, they would have to stand at the back of the room, because in some units, people would throw things on the nurses or grab or do things. So they had to stand to the back of the room when the medication was placed at the door flap. And apparently they implemented it in his unit, but they didn't tell people. And I think he thought that they were just doing that to him. As he didn't get his medication because he didn't stand in the back of the room, I think, for maybe a couple pill passes. And he made a suicidal gesture or an attempt to hang himself. Like I said, I was not there. I did see the video later, and I talked to him, and he said he was angry. I mean, he had told, I think, the counselor, I think he had told that, it was the anniversary of his children's death, but he didn't tell me that. He just was.
I'll show you another page of the records, and the records sort of go in reverse date order. Is that right? They start at the bottom.
Yes, that's correct on this page.
Now, in the days leading up to the 28th, was he talking about his Geodon?
Yes, he felt that it needed to be increased, this says. That was August 18th. And we did increase it. And he said after we increased it, he felt more angry, which sometimes the restlessness, the side effect, the akathisia, the movement can be an internal restlessness that people can interpret as anger. And I'm seeing if that's the day that that's not the day that I started the propranolol for the side effects. So I'm not sure why he was more angry, but it could have been more side effects, or it could have been a lot of things. I don't know.
On the morning of August 27th, 2015, is there a note about whether or not he got seen that morning?
Apparently he was scheduled to be seen in psych clinic that day, but they were unable to pull him. There was not enough security staff available, so I was unable to see him that day. And then the nurse said that because he didn't go to the back of the cell, they listed that as refusal of medication. If you don't fully comply with their rules, that's counted as a refusal, so. And he did not receive medication.
And then on the morning of the 28th is when he tried to hang himself.
Yes, I think so.
And you watched the tape from the night before,
I did watch the tape.
and can you tell ladies and gentlemen about how his actions were the night before?
He was very restless. He kept moving around the bed, getting up, lying down, getting up, lying down. I mean, he tied the sheet, I think it was the sheet, around his neck, and then he untied it. And I mean, there was some ambivalence about the whole thing. And finally, he did tie it, and eventually, and the staff came and got him out.
With regard to your diagnosis of schizoaffective disorder, did you have evidence of symptoms of hallucinations?
He told me multiple times that he hallucinated, yes, so that was my evidence, was his word, and I had no reason not to believe him.
And did you, through medication, were you ultimately able to resolve the hallucinations?
Yes, the auditory hallucinations stopped with medication. Occasionally, I think he still had the permutations would come and go, the things he would see, but the things he heard stopped.
Did you observe disorganized speech?
I wouldn't say it was disorganized. At times it was strange and wasn't, his thoughts would jumble back and forth between two topics, maybe. So more like flight of ideas, I might call that. But if you could separate those two things out, I mean, I guess they kind of made sense if you could keep up with several trains of thought at the same time. But he did have strange ideas, like one time he was telling me about the way he saw his psyche in a triangle, and I mean, wasn't disorganized really. I understood what he was saying, but it was strange.
Did you talk about that he had 3 personalities in him?
Yes, that was part of that, yes.
Would you consider that pressured speech?
He did have pressured speech several times, yes. That just, I could hardly talk because he had to get it all out, you know?
Is that sort of a hallmark symptom of schizophrenia?
Of more of an affective component, more on the, that would be leaning more toward like bipolar mania. But again, I have no documentation that he ever had a full-blown manic episode, but might hypomania or.
Is that why you said schizoaffective?
Yes, because of the affective components were the depression and the pressured speech and the agitation, and that could have been that.
Okay. Did you observe negative symptoms?
Absolutely. I mean, I cared more about his hygiene and whether they gave him clean uniforms or he got a shave or a haircut than he did. He didn't really, those things weren't important to him for a lot of time, and I'd have to go get the officer say, you got to get him a clean uniform, you know, because he didn't ask, he didn't really care. He's not a particularly talkative person, so I mean, that may just be his personality structure, that he doesn't talk a lot or explain a lot or anything, but there was paucity of speech a lot, but I'm not sure if that's just the way he is or if that could also be a negative symptom.
Do you medicate people who you don't believe are safe?
No.
In your opinion, is Tim Jones mentally ill?
Yes.
Do you have any questions?
No. No, I believe he's mentally ill.
Did I ask you to try and average out how many pills he was sort of taking?
You did. I can't remember. I did it for you, but I don't remember the numbers. As we were changing medicines and trying to treat side effects. I mean, sometimes he was on a lot of medications. And the Department of Corrections doesn't always carry the highest strength available of some medications. So, like, they make an 80 milligram Prozac, but we only carry 20, so 20 milligrams. If you want to give somebody 80, you got to give them 4 pills. I mean, it's part of the problem. At Kirkland, one of the times he was on the most pills, he was taking 10 in the morning and 8 in the evening. That was April of 2017. And when he was at Lee, which was toward the end, he was taking 3 pills in the morning and 5 pills in the evening.
It was 3 in the morning?
And 5 in the evening.
And that was until he left your care to go to
Yes.
Lexington Detention Center.
Yes, that's what he was on at the end of when I was seeing him, the 8 a day, yes.
Now, have you seen people on spikes, on synthetic cannabinoids?
I've seen a number of our inmates on synthetic marijuanas. I mean, usually we call it K2. I mean, there's a lot of variability in the synthetic marijuanas because you don't know what they added to it, yes.
And have you treated people that were on
Yes,
the K2 or the spikes?
yes,
Have you treated them with antipsychotics?
yes.
Do they require, how long do you treat them?
Well, generally, they're better within a few days. Those that have underlying psychotic disorders sometimes take a few months to get better.
Is Tim's condition a result of spice, or is he mentally ill?
Based,
Objection, Your Honor, outside the scope.
Rephrase that to stay within scope.
In your opinion, after having treated people for spice and treated people with mental illness and spice and treated people with mental illness, can you tell us what Tim's condition is in your opinion?
I believe he has an underlying mental illness. It could have been exacerbated by his drug usage. And certainly he used drugs that could change your brain's chemistry.
Does that make him not mentally ill now?
I think he still has, the last time I saw him, I thought he still had an underlying mental illness, and it's one that would not go away, so I would assume he's still mentally ill now.
But of course not. Do you know about how many times you've met with Tim?
I do not. I saw him consistently for a little over 4 years. In the beginning, I probably saw him every other week, sometimes every week, depending upon how things were going with him. His level of care when he was at Lee was outpatient mental health. Our policy requires us to see people on medication or outpatient mental health at least every 3 months. So, I mean, it went from more frequently to less frequently. And at Lee, it's a lot more difficult to get people pulled to be seen. So I didn't count the number of times, but I saw him a number of times. And I can't, if I didn't count them, I'm sorry. I don't know how many.
And could you estimate like how many hours over those 4 years you spent with him?
A lot. I don't know a lot, though.
Okay. Thank you, Dr. Wood. Please answer your question.
Good morning, Dr. Wood.
Good morning.
And I think when we spoke before, one of the things you indicated is that you're actually eligible for retirement. You've been a state employee for over 28 years.
Yes, you guys pointed that out to me, and I told you I like my job, so,
But,
yes,
and that's one of the reasons you're still doing what you do, because you like working with inmates.
I do.
And Dr. Wood, just to clarify how your role is different than a forensic psychiatrist, for example, your role is to determine what issues an inmate may have once they're in the Department of Corrections, correct?
That is correct. I don't, well, we don't have a lot of pretrial detainees, but for those we do, I don't talk to them about their crime unless it involves their current treatment, something from it. So, I mean, that's not my role, is to deal with their crime, but to deal with their symptoms and treat them. That is correct.
Treating the inmates for any symptoms that they describe once they're actually incarcerated.
That is correct.
And a forensic psychiatrist, and just to clarify, that's a separate form of board certification within the field of psychiatry, correct?
Right. That's like I mentioned that I did additional training in child psychiatry, but I chose not to work with children. They do additional training in forensic psychiatry. So.
And then the forensic psychiatrist would have the job of actually reviewing materials related to the crime to render an opinion about whether or not someone is criminally responsible or knew right from wrong at the time they committed their crime, right?
That's correct.
And that is a separate type of field than what you do.
That is correct.
And so to clarify, you are not here to give any opinion whatsoever as to his state of mind on the night of August 28, 2014, correct?
That is correct. I didn't talk to him about his state of mind on that date.
So part of your role in treating an inmate is you meet with them and you assess whatever symptoms they're describing to you at the time.
Yes.
And of course, you're looking for signs or behavioral symptoms that may correlate with that, but you're also interested in obtaining that history from the patient.
Yes.
And I believe that your work on the rectal examination, where as it relates to Mr. Jones, you said he told me, and my evidence was his work. And that's regarding...
For most of his history, yes.
That would be his history of voices, his history of hallucinations, things of that nature, correct?
Yes, that is correct. I mean, it's with hallucinations, you pretty much always have to take someone's word. You're correct, yes.
And then leading up to the trial of this case, one of the people that met with you and another one of his providers, and you can just inform us, who is Jim Page?
He's clinical counselor that works with me and that saw Mr. Jones sometimes with me or independently.
All right. And then who is Toshiro Inabinet?
Mr. Inabinet was he's now associate warden at Evans, but at that time he was the counselor in charge of the unit at Kirkland that Mr. Jones was assigned to, and he made regular rounds and saw the guys on a regular basis. He made daily rounds, and I think he made weekly notes of how they were doing, yes.
All right, so the treatment plan for an inmate isn't limited just to you, but you actually have other staff members who are seeing him on a regular basis as well.
That is correct.
And everybody makes notes, and you, as one of the treatment providers, have access to those notes and review those notes and take all of that into consideration in your treatment, correct?
Yes, I review some of the notes. I don't read all the group notes, and of course he wasn't allowed to be in groups because he can't mix with the other inmates, but in general, yes, I review a lot of the notes, not all of them.
All right. And then you and Jim Page, who you just told us about, and leading up to this trial, one of the things y'all did is y'all sat down and met with the court-appointed forensic psychiatrist, Dr. Richard Frierson, correct?
Yes, he did meet with us.
And you're familiar with Dr. Richard Frierson just from years of doing the psychiatry work that you did.
That is correct.
I'm sure it wasn't the first time you met with him about an inmate.
No, we see him a lot, yes.
And so when you guys sat down and met with Dr. Frierson, one of the things that was indicated that you had not seen Mr. Jones display disorganized thinking or behavior. Does that sound correct?
That's correct. I never saw him totally lose it and have disorganized behavior. I did not see that, no.
Another thing that was noted is that where Mr. Inhabitant is concerned, and I believe you told us just a few moments ago who he is and how he plays a role in the treatment plan, but he reported that although Mr. Jones complained of hearing voices, he was never observed to be responding to the stimuli one would expect with hallucinations. Are you familiar with that notation by Dr. or by Mr. Inhabitant?
I don't recall seeing it. Not all the people that hallucinate respond. I never saw him respond either, but a lot of them do not, and he was on medication every time I saw him except the very first time, so. But that's true, I never saw him respond to.
So in addition to the notes of Mr. Inhabitant, you would also agree that you never observed the defendant responding to any internal stimuli as if one were hallucinating?
Not everybody that I see that hallucinates actually responds to them. So I wouldn't say that discounts it, but I never witnessed that with him.
And I believe another thing you testified to on direct examination was about malingering, and you said that you yourself had not seen any signs of malingering.
That's correct.
Then I believe you also said that you weren't aware that the staff had observed that either.
That is correct.
Are you aware of the notation that is in his chart and in his records from August 28th, 2015, from the treating nurse, Justin Kuthankin, that what he was reporting about hearing voices, it's underlying data, Your Honor. I can rephrase that.
All right, rephrase it.
I believe that was discussed in your meeting with Dr. Ferguson, wasn't it, Dr. Wood?
I discussed it in a meeting with someone. Mr. Gudvangan was the HCA, the head nurse of that unit. He didn't actually come up there very often. So I don't know where he got the information for his note. That's the only, I did discuss that note with him afterwards because I was concerned about why he would say that, and I never got a reason why he would say that, so.
Okay. And that note specifically in the chart is a notation regarding malingering and manipulating behaviors, correct?
That's what Mr. Gudvangan said.
And specifically, it was because he had missed a dosage of Geodon and then immediately reported hearing voices. And according to the notation, he would not have experienced that after having missed just one dosage of Geodon, correct?
I wouldn't expect full-fledged voices to return with missing one dose. I think he missed 2 doses, but anyway, I would not expect that. He did miss a propranolol, I think, and I thought he might be experiencing some withdrawal akathisia, the abnormal movements, internal restlessness is what I thought. But yes, I did not concur with Mr. Gudvangan's assessment, and I don't know of anyone else who did.
All right, and I just wanted to clear that up because I think you had mentioned that the staff had not observed that, but there was in fact a notation about it.
Well, and he wasn't up there. I don't think he observed that either, but he came to that conclusion somehow.
Okay. And then, Dr. Wood, I know you addressed that there were no symptoms of disorganized behavior, but you were asked on direct examination about disorganized thinking. And I believe you said that there were sometimes thoughts that were flights of fancy, correct?
Well, flight of ideas, that he would be jumping from topic to topic and talking about strange things, but I didn't feel that it was disorganized. It made some sense to me. That's what I say.
It makes sense because ultimately there would be some type of purpose behind the thought, correct?
He was explaining to me how various things, yes.
And are you aware of the note in his record from January 2015? I do believe it's also something that you discussed with Dr. Frierson. But in January 2015, he was noted to be angry. He struck a door with his fist. He was then treated for, I believe, some cuts to his hand. But he reported that there were people on the outside who were giving his wife a pity party, and that made him mad, didn't it?
I recall seeing that note. That's what the note says. I mean, he never told me about that, but there is a note that says that.
All right, so that's not disorganized thinking. He's actually angry that people on the outside, on the street, have sympathy for his wife, the mother of the 5 children who were killed, correct?
I mean, that's what he told the person. That's all I know.
But you would agree that's not disorganized thinking.
That note does not indicate disorganized thinking to me.
And then on that same topic of disorganized thinking, there's also a notation in the record from May 21st of 2015 regarding homicidal ideations. Do you recall that?
No, that one I do not recall.
That would have been a notation made by by Page, who you mentioned earlier, that he reported homicidal ideations towards 2 people on the street. Wouldn't that be something that you would have taken into account and wanted to address during his treatment?
Every time I saw him, I asked him about homicidal ideation. I don't think he ever acknowledged that to me.
But again, that in and of itself does not represent disorganized thinking, does it? It would be a purpose or a reason behind that, correct?
That particular statement by itself, taken out of context, would not indicate disorganized thinking.
And then, Dr. Wood, about the Geodon, I just want to ask you a few questions about that because you were the prescribing physician on that, and of course those Geodon levels increased over the course of time.
Yes,
But Geodon can result in cognitive impairment depending on the dosages, correct?
that is correct.
And I'm going to show you what is State's Exhibit 196, being the publication from Pfizer, specifically about the side effects associated with Geodon. And then also State's 195, which would be his prescription history for that drug.
Mm-hmm.
So cognitive impairment is one of the side effects that goes along with that, right? Can be,
It can be, yes.
right? And in his case, I believe there were notations in his record about experiencing brain fog. I believe that was the words used in his chart. You were familiar with that?
Yes, he did describe that to me at one point in time.
So he was experiencing some type of side effect from the Geodon, which would be a normal reaction, correct?
For some people, yes.
And another one of those warnings that goes along with a drug like Geodon is that you're not supposed to drive, use heavy equipment, depending on the dosage, correct?
Yes,
So one would expect that you wouldn't want to conduct psychological testing if there are large doses of Geodon being prescribed, correct?
we never did a level. And again, if you don't have food, it's like half as effective. So, but if you had a high level, you are correct. So, I mean, I can't say for sure how much he actually absorbed.
And it can also affect simple tasks, like the ability to stay on task or the ability to stay on track, correct? In communications, things of that nature.
It could cause sedation, which could affect that.
And then some other possible reasons that Geodon would be prescribed to an inmate. Well, you've done your job so long and have treated so many inmates. Can you tell us through your own experience as a psychiatrist some of the other conditions that you have prescribed Geodon for?
Generally, we prescribe Geodon as an antipsychotic for people that are out of touch with reality or hearing things or seeing things, or as a mood stabilizer.
And when we talk about a mood stabilizer, just want to follow up on that because bipolar disorder on its own, even if someone isn't schizophrenic or schizoaffective, if they just have a mood disorder, serious mood disorder such as bipolar, Geodon is an accepted form of medication for that condition, correct?
Yes, Yes, it
And
is.
there are certainly physicians that prescribe it just
Yes.
for bipolar disorder.
Yes.
And is that something y'all have done there at the Department of Corrections as well?
Yes, we do.
Okay. Another known use for Geodon could be if a patient is experiencing severe insomnia. Do you know whether the Department of Corrections has provided that for inmates who experience insomnia?
No, we don't. We have very strict guidelines on insomnia. We don't use Geodon for that.
But it's acceptable just for a mood disorder in and of itself, correct?
That is correct.
And regarding a mood disorder, that's actually one of the things that you discussed with Dr. Frierson when you met with him, correct?
Yes, that I think there was a mood component to his illness. Because you can have bipolar with psychosis. So you can have primarily bipolar and still hear voices or see things, yes.
So when you did testify a few moments ago that it's your opinion as a psychiatrist that there is an underlying mental illness. A mental illness can include a mood disorder, correct?
Yes, it can.
You're not reaching an opinion beyond that at this point in time, are you?
No, I say he has a mental illness that has psychotic components and I think affective components as well. I don't think he neatly, in my opinion, didn't fit in any of the boxes completely, yes.
All right. Didn't fit in any particular box completely.
The diagnostic criteria, yes.
And then part of what goes along with trying to fit someone in a box or reach an actual diagnosis pursuant to the DSM, while we rely on this, but one of the components that goes along with trying to fit someone in a specific box in accordance with the DSM would be to rule out substance abuse, correct?
Yes, that's generally,
Because any underlying condition has to be explained that it's separate and apart from substance abuse, correct?
yes, that's generally an exclusion for most of them.
And as it relates to Mr. Jones, have you been provided his substance abuse records from the Department of Corrections in Illinois?
No,
And so a history that included multiple occasions of LSD or acid use, a hallucinogenic, in his teens, that would have been provided to you?
no, we did not have those records.
Or the heavy usage of crack cocaine, for example, around 2000, 2001, were you provided with that information?
Other than he told me cocaine was his drug of choice, no, we don't have that outside information. I mean, he did say he'd used a number of drugs. I'm pretty certain he did not use drugs during the 4 years he was in SCDC. So whatever effects he had were permanent changes, which may, certain drugs can cause permanent brain changes.
Well, and going back to the history that he's self-reporting to you about voice and hallucinations, crack cocaine when used at high levels can result in symptoms similar to psychosis, correct?
That is correct. But again, he told me that the voices started before the drug use, so that is the information that I had. So.
And then once he arrives in 2014, after his arrest for these crimes, he reported that he had been using spice, which is known,
Well, he said synthetic marijuana, yes.
known to contain the ingredient ABPNOC, correct?
Different, it contains lots of ingredients because you never know what people put in it, right?
And as it relates to ABPNOC, were you provided with specific information as to how often and how frequently he was using that up to the dates of these crimes?
No,
And were you provided information as to the known symptoms and side effects of ABPNOC?
just of general synthetic cannabinoids, not that particular one. Not one particular possible component, no.
Need a 5-minute break. So, hold what you got. You stay right there, doctor. Jury's asking for a quick break, so I'm gonna give it to them. Don't talk about the case. See you back here in a few minutes.
And Dr. Wood, I believe you were saying previously that you were not provided his records from his treatment within the Department of Corrections in Illinois, correct?
That is correct.
Back in 2002. So part of his drug history being the self-reported use of acid and cocaine, that was not information that you would have had in making your assessment, correct?
Not their records, no. I did not have their records.
And the fact that when he was arrested in 2001, it would have been the raw form of cocaine or crack cocaine, that would not have been information that you had.
I did not have any information about the 2001, no.
But he reported that his drug of choice had been cocaine, at least at some point prior in his life, correct?
John?
Your Honor, we reject, that's not a correction of the false statement of having crack cocaine.
Let me ask you this
All
way.
right, rephrase your question and, consistent with the evidence that's been presented.
Doctor, you're familiar with him having used cocaine in his past, correct?
He did say that he had used cocaine in the past.
And indicated to you that it was his drug of choice, correct?
That is correct. He said it was his drug of choice, but I don't think, when he talked to me, that was not what he used most often, but it was his drug of choice.
And when he talked with you, what was it that he used most often?
The marijuana, and maybe the synthetic marijuana as well, I don't recall.
And I believe reported that he had been using that throughout his life since young teenage years, correct?
Yes, he had started using it as a teenager, I think.
Now, Dr. Wood, in reaching a diagnosis under the Diagnostic and Statistical Manual of Mental Disorders, the DSM, it helps have a clear picture of one's daily activities, correct?
Yes,
In terms of what they're thinking, how they're behaving, anything along those lines, right?
it is. Yeah, it's helpful to observe them.
And doctor, in modern society, a smartphone can be an essential tool in examining someone's daily activities. Do you agree with that?
I'm not sure what you mean.
Communications through text messages, that can be a reflection of one's thoughts and communications.
Yes, that can. Of course, he did not have a cell phone while he was with us, so.
And smartphones can contain one's internet search history, calendars, appointments, anything along those lines that go to show one's daily thoughts and behaviors, correct?
Object, relevant.
Staying, move on.
You didn't have any information, Dr. Wood, that had been provided to you regarding the extraction from the defendant's phone up through August 28th, 2014, correct?
No, I did not have any information about his phone.
And so the extraction was not provided to you by the defense prior to him calling you as a witness today?
No, I did not see any information about his phone usage.
And then in reaching your determination as to his current mental illness, I believe was your testimony on direct examination, were you provided any work performance records, evaluation reports, things of that nature to show how he was behaving and thinking leading up to his incarceration,
No, I had no records.
including work records?
I had no records of any kind.
Thank you, Dr. Wood.
Dr. Wood, are you being paid by anybody being here?
No, sir.
You're just the treating psychiatrist?
Just the treating psychiatrist, yes, sir.
Do you need to have disorganized thinking in order to be diagnosed with schizophrenia or schizoaffective disorder?
No, that's one of the list of criteria that you have to have at least two of, but you don't have to have that particular one, no.
Thank you, Dr. Wood.
All right, you may step down. You're free to go.
Thank you.
All right, Ms. Young?
Defense called Dr. Julie Torney.
Solemnly swear or affirm the testimony about the truth, the whole truth, nothing but the truth, so help you God. I do. Have a seat right up there, Leah. Once you see it, speak up loud and clear, state your name and spelling your name.